Hi, good evening, Room Now. This is Robert Chao reporting live from ACR 2021. I'm joined today by my colleagues and friends here at the Room Now faculty for the Spondyloarthritis and Axial Spondyloarthritis faculty group. We would like to share our sort of wrap up and our thoughts on the highlights from this category in ACR 2021. So without further ado, let me introduce everyone. Let's start with Tony first.
Hello, I'm Antoni Chan. I'm a consultant rheumatologist in London, United Kingdom, and really happy to be here with the XPA group.
Thank you. Rachel?
Hi, guys. I'm Dr. Rachel Tate. I am in West Palm Beach, Florida, and this is an amazing team to be part of.
Great. Sheila?
Hi, I'm Sheila Reyes from the Philippines. I'm a consultant rheumatologist, and yes, I'm really happy just to be part of the group and discuss what's new and what's up to date with Axial Spa.
Great. And last but not least, Akhil.
Hi, my name is Akhil. I'm an internal medicine resident at University of Texas in Galveston. I'm happy to be here and talk about ankylosing spondylitis.
Wow. So Akhil, you're beating us all. I don't think any of us could talk about ankylosing spondylitis as a resident. So props to you. Thanks for joining. So with that being said, actually, Akhil, you start us off with what was your highlight of this conference in our category?
Yeah. I mean, there are quite a few interesting abstracts out there. I guess one of the ones I saw was abstract 562, which talked about inpatient hospitalization and resource utilization in patients with ankylosing spondylitis. They used the National Inpatient Sample, this large database, and they looked at hospitalization in patients with ankylosing spondylitis. Just because from previously in the literature, there's not much information regarding hospitalization in patients with AS. And they found that the hospitalization rate was relatively high in patients with AS, at approximately 1 in every 2,000. And they found that compared to the general population, the odds of ICU admission were high, and even the length of stay was high, and the costs were relatively high as well. And I thought was really interesting was that the most common reasons for admission to the hospital were infection-related diagnoses like UTI, pneumonia, sepsis. And I just think this is a really interesting area and will be interesting to explore in the future.
Yeah, that is very interesting. You know, I think my initial thoughts on that would be, does everyone think, or do you think that's more the AS driving the hospitalizations, or perhaps the treatment they're on? Did they mention, you know, how many were, let's say, on biologics versus not?
Yeah, that's a good question. I don't remember the exact details of like the treatments of what they're on. That would be definitely something really interesting to see, and you know, what drove the hospitalizations, if they're not well controlled, or certain treatments may drive it more so than others.
And Akhil, I think that when they looked at this information and this data up front, they were really talking about upper respiratory tract infections, pneumonias, things like that. And I believe this was earlier than COVID. So it might be interesting to see like what that data actually looks like now too. And as we progress through not only a pandemic, but into the future with other treatment options and modalities.
Definitely. Yeah, that would be really interesting to see, especially before and after COVID, and even with like different biologics as well, seeing how that can impact the outcomes.
For sure. Okay. Thank you very much. Sheila, do you want to share with us your favorite abstract?
Okay, my favorite abstract, which I think is also a favorite within the group, is abstract number 1919. So it was presented earlier today in the abstract session. So it's about an artificial neural network to detect radiographic sacroiliitis in the diagnostic setting. So this was done by the group of Dr. Dennis Padabny. So they saw that the sensitivity for the detection of radiographic AxSpA was 78.7%, but a high specificity of 93.9%. And that was really well, as Dr. Padabny said, the specificity was really important, especially in imaging techniques like this, because you know, that would really help identify those that do not have the disease. And so it makes the test more reliable and more helpful in detecting sacroiliitis. And the reason why I think for me this got me interested is because this can be the future in imaging of axial SPA. Especially, we know that MRI is really on the higher price of things, and not all areas get MRI has good accessibility with MRI. So if we are able to use X-rays in detecting earlier our patients with AxSpA, then that would be a good test for everyone. And it can also standardize, it can be a tool to standardize imaging in AxSpA, especially in clinical trials. So I think there's lots of potential here with that artificial intelligence thing that they did.
Yeah, I think we're having a lot of discussion about this even pre, panel. So feel free to chime in, everyone.
I think it's a really interesting and nice and practical post. I think the focus is not so much on the diagnosis, but more in terms of the classification of, as you know, the classification can be quite challenging. The lower grades, especially grade 1 and 2, you can make your pick. On some days it can be 1, and some days it can be 2. I think it's very easy when it's fused, or you've got bony ankylosis, but in the lower grades it's difficult, and a lot of time goes into validating, sometimes 2 or 3 radiologists disagreeing about it. So if we can find a way where we can use a method like this, artificial intelligence, to standardize it for clinical trials, for research, I think that would be a way forward.
I agree, Tony. I think this is one of those potential game changers for us. And even as you mentioned with radiologists, there's dissension amongst them too. If you don't have a musculoskeletal radiologist reading your films, this could be something we could actually utilize and have easy access to. And of course, machine learning is kind of the wave of the future, as Sheila mentioned too.
Right. And I think this actually brings up pretty good from the last panel some of us were on with the psoriatic arthritis. And there was discussion of this abstract where they had this pretty simple algorithm of dermatologists referring, patients with back pain, chronic back pain to rheumatologists to evaluate for possible axial spondyloarthritis. So I think if you add on to that rather simple algorithm, and then perhaps add on the CNN neural network, you have yourself a pretty, darn good evaluation, and probably just comes to you ready, already with the diagnosis perhaps. So I think, yes, definitely a wave of the future. Rachel, do you want to share with us your favorite abstract?
So I know we were talking about this a little bit offline. I was really interested overall in some of the imaging and progression abstracts this year. I think they were all really, really good. And especially when it comes to the kind of concept that we have, or the dogmas that we have surrounding AS. So one of my favorite abstracts was number 0907, and that was Dr. Kieskamp et al. And as I'll kind of frame this way, there's a lot of controversy regarding non-radiographic AxSpA. Is it early AS? Do these patients progress? Do they respond to therapeutics the same way? We all have these questions, but essentially this group operated under the dogma that 10% approximately of non-radiographic AxSpA patients do over a 2-year period progress to AS. And they were spot on. They looked at patients for a 6-year cohort, and they looked at patients every 2 years with additional imaging, and found that really it was about every at the 2-year mark, about 10% more patients who were originally non-radiographic AxSpA had actually converted, if you will, into AS patients. And this was obviously done by modified New York criteria, all the criteria we're used to seeing within all of our RCTs. But what this makes me, it kind of gives me reassurance that we'd already seen this from a German cohort, that patients about 10 to 12% every 2 years will progress. But it makes me also think, am I missing this in my patients? That I'm going ahead and I'm saying, okay, you're non-radiographic AxSpA, but what if they are progressing? Even on these therapeutic agents, as we normally think. I think you guys are experiencing some of these questions too. What are your thoughts?
Yeah, I think a really important point there, Rachel. I think what we're showing us is that non-radiographic and radiographic have similar burden of disease. It's not that one's milder, one is just purely earlier. I think the key thing is about risk stratification. How do we stratify people who are going to be progressors? And some, because it's interesting in the study, there are some who don't progress as well. In fact, there's some look like they regress. So I think that's also an important research question. I think what we know is that race CRP and the presence of baseline syndesmophytes or baseline radiographic change seem to accelerate, because there's another study that showed that most of this was happening between 30 to 39 years of age. But if you had radiographic progression, you kind of brought that forward by probably a decade. So, those people, we probably should go harder with our biologics if they are known to have increased risk of progression.
Yeah, I agree. So it really boils down to, because at this point it's still hard to identify if this is axSpA, is this our patient's going to progress. So it's for us clinicians, it's always the question of whether, okay, so what am I going to do with my patient? What medicine or what choice of treatment would really benefit them? And sometimes we know that it's a spectrum, so there's always that question of, okay, so who's going to progress and who's not going to progress? And early identification is key when it comes to axSpA. So there.
Yeah, no, I think all very good points. Thank you so much. And last but not least, Antoni, do you want to share your favorite abstract?
Yeah, so I was very interested in the whole area of dose tapering. There were two nice posters from the Danish group, 364 and 929. One was looking at if people have very low disease activity for a year. So if their BASDI score was less than 40 and the physician global was less than 40, they could dose taper, but in a stage-wise manner, not stopping it completely. So they went 2/3, half, a third, or zero, and up to 52% of them could last on a dose taper for another year. But some did flare. So the people who flare, it turned out to be that the physician global assessment is the greatest predictor. In other words, if you are the rheumatologist and if you think that these people are not suitable for flare, you're probably right. So that goes back to your clinical suspicion. And some people, perhaps there are other factors as to why they may not be so suitable for dose taper, and some will. So I think it's just a nice study showing that clinical assessment is still quite important.
Of course, it's important. I like to
very
think,
much.
Even though it's machine learning we're talking about to some degree today, there's still a role for us. No, I agree with you, Tony. I thought this was really interesting overall. I hope and I aspire to continue to have good physician globals. I mean, I think that's something we all need to keep working on, and there's so much emphasis on a good history, a good physical, and we need to keep that. Akhil, I'm sure you're seeing that in training too. We need this. We have to have this. It's a combination of everything.
Yeah.
Yeah, and I think the really interesting thing with that study, actually, I brought it up with Dr. Cush in one of the daily wrap-ups, was that even with MRI findings, the physician global outpaced it. And so I think all of this is just, I think much like you said, you trust your gut, and hopefully the patient listens to you. Any last comments from anyone before we wrap it up here?
I would just like to point out one thing. Akhil, you must be with a really good team, because I hear the goals won knowledgeable, and we're looking forward to you joining rheumatology in the future.
That's
and
right.
Jumping on board to knowledgeable as well.
Definitely, yeah. I would love to join during fellowship. Absolutely.
That's great. All right. If no other questions, I hope you all enjoyed our wrap up here with the spondyloarthritis faculty group. We look forward to seeing you all next year, hopefully in person, and maybe we can all share a cheesesteak in Philadelphia. Otherwise, tune in to roomnow.com for coverage of ACR 2021. Take care.